I have an interesting bio to read here. Our next speaker is John F. Lund, a graduate from Brigham Young University with a BS in electrical engineering in 1992. He then went to work as a computer program for Utah Medical Products, continuing as an independent contractor and employee for Tato Entertainment, Sculptured Software, Acclaim Entertainment, that may be one word, where he developed entertainment software for Apple, HGS, Nintendo, and Sony PlayStation. He was a fun guy. Then his life took a serious turn. In 1996, he graduated as an MD from the University of Utah School of Medicine. He did his residency in internal medicine at LDS Hospital in Salt Lake, and then he did his cardiology fellowship at the University of Utah, general cardiology from June 2000 and 2002, with research on electrophysiology, and his subspecialty was achieved at the University of Utah Electrophysiology Fellowship 2003-2005, and holding the chief fellow position from 2002 to 2004. He has been established at McKay-D Cardiology since 2005, where he works, no surprise, as an electrophysiologist cardiologist. So, Dr. Lund, I hope you still get time to play with games and make little inventions and get royalties.
So a lot of times people ask me, why did I end up in cardiology if I started out in video games? And my answer is I ended up in video games because electrophysiology is about the closest thing that you can find in medicine to video game programming and video game playing. But what I want to talk today about is electrophysiology, what's new, where are we now, and where are we going? In particular, I think the topics that are important, number one, pacemakers. Pacemakers have been around for a long time, and you might think that they're a very mature field and there's not much more that can be done, but there are some significant advances that are being made in pacemakers. Sudden cardiac death and defibrillators, this is a huge area of interest right now. A lot of money is being spent trying to improve defibrillators and the efficacy, reduce inappropriate shocks while making sure that we shock patients appropriately for ventricular tachycardia and lethal arrhythmias. Cardiac resynchronization, I think, has become one of the most interesting areas in cardiology at this point. Being able to treat patients with congestive heart failure where all medical therapies, all other therapies have failed and still have 70% success rates as far as responders. Then I want to talk a little bit about SVT ablation. Again, SVT ablation has been around for years, but we have a lot of room where we need to grow, where we need to make improvements. And then finally, probably the area of most interest right now, atrial fibrillation ablation. I think we're finally approaching an era where atrial fibrillation ablation is coming into prime time. I've been very conservative because atrial fibrillation ablations carry significant risk, have fairly low success rates, but we're getting much, much better now, getting more information. And when it comes down to it in electrophysiology, it's all about the information. People typically will come into an electrophysiology lab as visitors to try to see what's going on. They'll sit patiently for about a half an hour and then politely make an excuse that they have to leave and say something like, I have no idea what's going on here. And the reality is, half the time the physician doesn't know what's going on during an electrophysiology case. Don't tell anybody, but the reason is because we just don't have all the information that we need. We're working on that, and that's where electrophysiology is headed. So speaking about pacemakers, obviously, again, pacemakers have been around for years. Their indications really haven't changed much in the last 20 years. Indication is for symptomatic bradycardia. Chronotropic incompetence is something we forget about. Patients who don't have heart failure but have dyspnea on exertion or increasing fatigue, oftentimes their heart rates don't increase, even though their resting heart rate may be 70, 80 beats per minute. Their exercise heart rate may be 70 or 80 beats per minute. So don't forget about assessing these patients with exercise protocols. They can be referred for what we call a chronotropic assessment exercise protocol treadmill test, and we can differentiate different causes of fatigue and dyspnea with exertion. And a lot of those patients will benefit from pacemakers, even though they're never documented to have bradycardia. And then obviously second degree type 2 and third degree AV block are indications for pacemakers. So what's new? Well, one of the big areas of well, first of all, just looking at it, I think everybody understands that the implants for pacemakers are very simple. These are 30 to 45-minute procedures. We just gain access to the subclavian vein and put a couple of wires into the heart. And the success rates, the longevity of these devices are very, very good. But as far as what's new with pacemakers, home monitoring. Everybody who gets a pacemaker nowadays gets a monitor that goes by their bedside, and every night when they go to sleep, the device is interrogated, checking things like battery status, arrhythmias. We can detect if a lead has fractured or dislodged from the heart, et cetera. And that information then is transferred back via the internet to the referring physician. And this increases the longevity and at least the reliability of pacemakers so that we can detect problems right away before a patient has a real negative event because of device failure. Another feature that's coming later this year is MRI-compatible pacemakers. Up until now, it's contraindicated to get an MRI scan on a patient who has a pacemaker. And that's been a real problem because a lot of patients who have pacemakers also have other medical problems that require MRI scans. So we'll see the first MRI-compatible pacemakers this year, and probably within the next 2 years we'll be getting MRI-compatible defibrillators as well. So that's going to be a big advantage. And then finally, as far as gathering more information, not necessarily pacemakers, but loop recorders have been around for years. A loop recorder is a small device that we implant on the chest to try to detect arrhythmias. So if you have a patient who has recurrent episodes of syncope, we can implant this loop recorder. Oftentimes, the syncope will only occur once a month or once every few weeks. We implant one of these loop recorders. It can stay under the skin for 3 years. It has a computer to automatically analyze arrhythmias and record any abnormal arrhythmias similar to what's in a defibrillator, and then report that back to us. And the information can be received through the same home monitors that we give to pacemaker patients so that we can detect arrhythmias and treat them sooner rather than sort of fumbling around and making the patient present to the emergency room in heart block before we can give them a pacemaker. What's new is going to be injectable loop recorders. Now this, I have to be honest, is not an injectable loop recorder. This is a microchip for a PET. But I don't have a picture of an injectable loop recorder, but they're very, very similar. They have a small computer memory, a small battery. They're actually injected as an outpatient office procedure under the skin, can be removed in about a 10-minute procedure, and have enough battery to last about a year. So there's no significant scarring, very simple procedures. And I think we're going to be seeing a lot of this stuff. The Medtronic actually has one of these that's expected out later this year as well. So that's kind of pacemakers, one of the least interesting areas, but still a lot of things going on there. What about sudden cardiac death? Defibrillators have been around since the 1980s, used to be implanted in the abdomen, now are implanted the same way pacemakers are. The indications for defibrillators have really boiled down to an ejection fraction of less than 35%. Patients who have been treated and continue to have an ejection fraction of less than 35% are candidates for AICD implant because their risk of cardiac arrest is around 10% per year. So, patients who have gone on for 10 or 15 years, have never had cardiac arrest, have had a low ejection fraction for all that time, remain at the same risk as they did 10 or 15 years ago. The risk for cardiac arrest doesn't go down. It probably actually goes up the longer you don't have cardiac arrest. So don't be lulled into a false sense of security because you have a patient who has had congestive heart failure for 20 years and has never had cardiac arrest. Anybody with an ejection fraction of less than 35% is at high risk for cardiac arrest. Again, they're implanted the same way that pacemakers are. What's new, again, is home monitoring. With defibrillators, because we're implanting these in patients who have heart failure, we also include a wireless weight scale, wireless blood pressure cuff, and then a device that can ask the patient questions about quality of life. And the primary care physicians can gain access to this information as well as the cardiologists, the heart failure specialists. And we gain a lot of data that helps us to ward off an episode of heart failure exacerbation rather than requiring us to wait for the patient to be severe enough to come in and have to be hospitalized. The information that we gain, weight, obviously. We can obtain pulmonary impedance from the defibrillator, measuring the resistance between the lead in the heart and the can in the chest wall. So we're measuring the resistance in the lung. If there's a lot of fluid in the lung, the fluid conducts electricity better than air, and we have a lower impedance. So we can detect the presence of pulmonary edema even at early stages before the patient has symptoms. We can detect arrhythmias like atrial fibrillation, and those can be transferred to the physicians. Daily activity, these devices have accelerometers, kind of like your iPhone does, and it can detect how much the patient's moving, how much the patient is active, and oftentimes patients' activity drops off long before they notice that they have symptoms. So if we see activity dropping off, it can be a red flag to increase Lasix doses or bring the patient in to monitor them more closely. And finally, with all of the information in the news about device recalls and device malfunctions and lead fractures and those kinds of things, we can learn within 24 hours if a patient has any kind of device malfunction with one of these home monitors. So it gives us a lot of additional information that we've never had before, being able to monitor the patients. All the patient has to do is go to sleep at night. There's no process where the patient has to go through to communicate with the device. They simply have to be within about 30 feet of their home monitor, which is usually next to their bedside, and all the data from the day or any information that's new is transmitted to the physician, and then we get a report the following morning. And even this is improving. We're going to the point where these devices will actually have embedded cell phones, and we'll be able to receive live or near live data as far as how their device functions. They don't have to have a bedside monitor, for example. So defibrillators, again, a fairly mature technology that's really improving in order to give the physician, the clinician, more information as to how to treat their patients. So what about cardiac resynchronization? Well, the indications are very similar to the indications for defibrillator implant. Ejection less than 35%. But here you have to have a wide QRS, because the wide QRS is the indication that there's dyssynchrony. In other words, the heart is not squeezing in a synchronized fashion the way it's supposed to. It's squeezing in a dysynchronous fashion. And I'll show some pictures of that. They have to be on maximal medical therapy for at least 3 months. These are expensive devices, and Medicare, Medicaid have decided they don't want to pay for these for patients who are going to get better anyway. So they require a 3-month waiting period. There used to be a requirement that the patients have class 3 or class 4 congestive heart failure. We had to wait for them to develop severe symptoms before we would allow them to get one of these devices. But it makes a lot of sense, and it always has, that we should catch these patients early before they've developed the class 3, class 4 congestive heart failure. Although the only data that we've had have been in those patients. But just this year, a study was published called the Made It CRT trial, where they looked at patients who had class 1 and class 2 congestive heart failure and found that, no surprise, those patients actually benefit more from resynchronization than the ones that we wait to have severe heart failure and try to bring them back from the edge. It's better to prevent them from deteriorating. So now the only requirements are the wide QRS and the ejection fraction less than 35% with or without symptoms. And this is actually pretty amazing. I mean, you say 70% success rate, that sounds a little bit low. But if you think about it, these are patients who have had revascularization, patients who are on beta blockers, on ACE inhibitors, on maximal medical therapy, who have, been diuresed and are euvolemic, and still, despite all of that, are in significant heart failure. And 70% of those patients will respond, and I've seen dramatic improvements in some patients, even normalization after everything else that we can possibly do. So 70% is really exciting. We'd like to get that higher. Right now, we don't know who we should select. We don't want to give these devices to patients who aren't going to benefit, but we don't have data. We've looked at echo criteria. We've looked at symptom criteria. We've looked at multiple different things, ischemic versus non-ischemic, and nothing seems to pan out as far as predicting who's going to benefit. But still, 7 out of 10 patients do respond to resynchronization therapy. So I think it's very important. What's new? Well, we have the same home monitoring that we've had for ICDs, for CRTDs as well, so that's very helpful. We have a lot better tools to implant these now. Implant times are now less than 2 hours. When I started doing this about 10 years ago, we would easily spend 4 or 5 hours. This is a little graphic of how we implant it. The first thing you do is gain access to the subclavian vein, put a guiding catheter into the coronary sinus, and then inject some contrast to define the coronary sinus anatomy. And then this is going to show implanting the other 2 leads, because we still have to put the full pacemaker or defibrillator system in. So this is a lead going into the right ventricle, and then a lead going into the right atrium. Then go back to the coronary sinus, pass an angioplasty wire, the same wires that they've been using to do angioplasties and stents for years, down the coronary sinus into a branch vein, and then the wire, the lead, goes over that guiding wire. You pull the guide wire out, and then finally you pull the guiding catheter out, and you're left with a wire on the left side of the heart. So now you have a wire in the coronary sinus on the left, a wire on the right, and you can resynchronize the heart by pacing both sides at the same time. This is just an example of a patient that we had at the University of Utah who had cardiac resynchronization. This is an echocardiogram. This is the left ventricle. The lines kind of delineate the endocardium, so you can actually see that this is the chamber of the left ventricle. And if you look at this, every segment of the left ventricle is squeezing, but they're not all squeezing at the same time. And because of that, you don't diminish the size of the ventricle maximally. The ejection fraction, or the percent of blood that's squeezed out with each heartbeat, is really quite low, and I'd estimate that at around 20%. Well, this is 5 minutes later. We've now turned on the patient's left ventricular lead. Here the left ventricular lead was turned off. Here the left ventricular lead is turned on. And if you look, you can see that now all the segments are squeezing more or less at the same time. So the heart is doing the same amount of work. It's squeezing just the same amount. Each one of the myocardial segments is squeezing the same amount. But over here, you've got a much higher ejection fraction. And when you multiply that over hundreds of thousands of beats per day, millions of beats per year, the heart actually remodels, becomes smaller, more efficient. The ejection fraction remains elevated. And this is kind of what we expect to see with cardiac resynchronization. When we get the lead into a good spot, pace both sides of the heart, we get really good outcomes as far as how well the heart functions. And that translates into improved symptoms for the patient. There's been data to show that by improving the squeeze of the heart, we reduce mortality. Patients live longer. Just as you would expect, it basically reduces all of the negative effects of heart failure. And again, this is in patients who have already gone through all of the maximal medical therapy, interventional therapy, bypass surgery, et cetera, and are not doing well. So what about SVT? Again, SVT ablations have been around for years. Started doing the first SVT ablations in the 1980s. They required open heart surgery. Now all these procedures are done percutaneously, similar to an angiogram or an angioplasty. Cure rates are around 90% for AVNRT, Wolff-Parkinson-White atrial flutter. Procedural times are 2 to 3 hours, generally sometimes less than an hour. They're always done as an outpatient with conscious sedation. And in general, we don't even need follow-up for these patients. It's a curative procedure. Patient doesn't need to be on any medications. What's new, if you look at the type of catheters that we use, the big difference now, catheters have small holes in the tip so that we can pass cooled fluid through the tip. When we are ablating the heart, we're passing about 100 watts of energy, lighting up a 100-watt light bulb in the heart right through that distal tip. And that causes char to form, steam to form, steam pops within the myocardium that can actually perforate the heart, and it limits the amount of energy that we can deliver. So now what we do is we cool the tip of the catheter with saline, and that allows us to deliver more energy directly to the heart and create larger more uniform lesions without as much risk to the patient. And cool tip catheters have been around for about 3 or 4 years now and are really changing the way we do ablations and the success rates. We can now burn about 1 centimeter deep and 1 centimeter wide with each lesion that we create. So we can burn deeper areas of the heart. Before, we were limited to about 5 to 6 millimeters in depth. So we can burn areas that are much thicker and still have success rates. Another huge advancement in ablations in general, in SVT ablation, is the use of 3D mapping technology. In the past, what we would have to do is just put catheters in the heart, use the electrical signals to try to determine where we are, use fluoroscopy, which is a very imprecise way of locating catheters in the heart, and burn until we got some sort of a result. Now what we'll do is we'll obtain a CAT scan or an MRI scan the day before the procedure, and then we use technology that uses magnets to triangulate and locate the tip of the catheter within the body of the patient, place the catheter at strategic locations within the patient. This is, for example, the left atrium, the pulmonary veins, the right, the left pulmonary veins coming off, looking at the heart from behind. We can register the patient to the MRI scan, and now we can burn within a virtual geometry in the cath lab using the computer model as opposed to actually using the patient. And that allows for things like this, where we can actually fly into the left atrium. So this is a view where we've cut the left atrium in half. We're looking out the right superior, the right inferior pulmonary veins, and we actually can see our catheters moving around in real time on this artificial geometry. And these red dots are lesions. These are spots where we've burned. So we know where we've been, we know where we haven't been, and very accurately we can produce lesions within the heart. And that allows us to have a lot more information to know where we're going. Now, atrial fibrillation, again, this was sort of the, this is the holy grail of atrial fibrillation, of electrophysiology, to try to be able to treat atrial fibrillation. 10 years ago, we really didn't have any ablative techniques. The medical therapy has been around for a long time, and don't forget about medical therapy, because a large percentage of patients can be managed very, very well with medical therapy, particularly if we use rate control. There's nothing new in rate control in the last 30 years. Digoxin, diltiazem, beta blockers are the staple of rate control, and really the only drugs available for rate control short of AV node ablation and pacemaker implant. But this is often all we need to get control of atrial fibrillation in our patients. When we need to, we move on to drugs, and again, these have been around for a long time. The older drugs are mainly limited by their toxicities and by the low efficacy. Although amiodarone is highly efficacious, it's also by far the most dangerous medication, causing pulmonary fibrosis in a significant portion of patients who have been on the drug for more than 10 years. It's an irreversible lung damage, and we can't use amiodarone because of that. So because of the negative effects of these older drugs and the lack of safety, we're starting to see some of the new designer drugs come out. Ticasine is basically sotalol, where they've removed the beta blocker effect, so you don't have the beta blocker side effect. You can use higher doses of the medication, gain a little bit more efficacy while not having as much of the beta blocker side effect. It can cause torsade. We have to monitor it very carefully. It's a very expensive drug. Dronedarone was just released about 6 months ago, and what dronedarone is it's amiodarone where they've removed the iodine. So we don't have the thyrotoxicity. The iodine causes the pulmonary fibrosis, so we don't see the pulmonary fibrosis. Unfortunately, removing the iodine, removing the danger, has also lowered the efficacy. But it's a great drug for patients in whom it works because there are very, very few side effects and no dangerous known side effects. So just really quickly, going on to ablations for atrial fibrillation, success rates aren't where we are with other ablations. Between 50 to 80% depending on patient selection. The complication rates are around 2 to 4%. Most of those are minor complications, but complications include stroke, tamponade, Atrioesophageal fistula, one of the things that electrophysiologists learned that surgeons knew all along is the atrium sits right up against the esophagus. When we burn on the posterior wall of the atrium, we can also burn the esophagus. When that happens, the body's natural response is to form a fistula. And if you can imagine, a fistula between the atrium and the esophagus is catastrophic, either bleeding to death from the atrium into the GI tract, or even worse, getting air and food from the esophagus into the left atrium. Almost uniformly fatal. Fortunately, occurs in less than 1 in 2,000 cases. We do things to try to reduce it, but we haven't eliminated it. This is sort of where we want to be. This is the maze procedure, the Cox maze procedure. What the surgeons have been able to do in the past, this is looking at the left atrium and the right atrium from behind. These are the pulmonary veins. The surgeons would cut the pulmonary veins off of the heart, sew them back on, cut a line down to the mitral valve, line down through the inferior vena cava and down to the tricuspid valve, cut off the atrial appendage, sew everything back together, and this would cure atrial fibrillation in 95% of people. The idea being that small areas of myocardium cannot sustain atrial fibrillation. Large areas can. You cut it up into small enough areas and you're not going to have atrial fibrillation. So we're trying to duplicate this. Very high success rates. The problem with this, obviously, is morbidity and mortality. It requires long pump times for all of this sewing, oftentimes repeat surgeries to go back and fix areas in the heart that begin to leak, etc. So what we do now, what we used to do is place lasso catheters across the septum into the heart and gather information locally around the pulmonary vein, and then hope that we were actually in the pulmonary vein and burn around the pulmonary vein. This only gave us information as to what's going on right where we were. There were high risks. There was pulmonary vein stenosis because we were often in the vein and didn't know it, and then the vein will stenose and people would lose lungs and lobes of lungs because of that. So now we use the three-dimensional mapping techniques. Again, this is a CAT scan of the heart. These are areas that we've burned around the pulmonary veins, and we can try to duplicate the lesion set that the surgeons have been able to do for years. The dilemma is that the best candidates for ablation are also the best candidates for medical therapy. So we always try to use medical therapy first. What's the ideal patient? Less than 65 years of age, no congestive heart failure, paroxysmal versus persistent or chronic atrial fibrillation, patients with high symptoms. Who do we usually get? Patients in their 70s and 80s, ejection fraction less than 35%, chronic atrial fibrillation, or patients who simply want to get off Coumadin. So very quickly, what do we use for selection criteria? Well, I require, and the American Heart Association recommends, that a patient fail at least one antiarrhythmic agent, including a good trial of rate control, have high symptoms. We do not do ablations to get patients off of Coumadin. I use the CHAD score, congestive heart failure, hypertension, age over 75, diabetes, and stroke. If a patient has more than one of these risk factors, they need to be on Coumadin before and after an ablation, with success rates being only 50 to 80%. Failure rates are fairly high, so the risk of developing atrial fibrillation and stroke is high. If they needed to be on Coumadin before, they need to be on Coumadin after. Patients with class 4 heart failure are bad patients for this procedure. It's a long procedure. It's a risky procedure. Anything that goes wrong in a class 4 heart failure patient is likely to be catastrophic. And patients have to be less than 300 pounds, which is the limit of our cath labs. Now, one caveat about using Coumadin is there is a new device called the Watchman left atrial appendage closure device that can be placed in about 25 minutes in the cath lab. We can occlude the left atrial appendage, and we may be able to get patients who we've ablated off of Coumadin by implanting one of these devices. So that the vast majority of clots come from the left atrial appendage that cause stroke. Therefore, if we occlude the left atrial appendage, we won't have those anymore. These are currently undergoing human trials at IMC and other places around the country. So that's it. Hopefully, we're developing this technology not for mediocrity, but to actually improve things, even though, mediocrity does take a lot less time, and people don't usually recognize the difference until it's too late. That's it. Any questions?
Can you talk about the mini maze?
Yeah, so the mini maze.
I had it done.
Yeah.
3 years ago.
The mini maze is a good procedure as well. It's a surgical technique where we don't require a median sternotomy. Instead, we can go through thoracotomy on both sides. And the surgeons essentially do the same thing that we do from the inside. They just do it from the outside. They burn the lesions instead of cutting and sewing. The mini maze has higher success rates than the ablative maze, the one that we do. Mini maze success rates are around 80 to 85%. The morbidity of the mini maze procedure is much higher because thoracotomies hurt, higher risk of infection and those types of things, but they can also remove the atrial appendage at the same time. My current strategy is to offer a patient an ablation because it's an outpatient procedure that doesn't have near the recovery time, and if that doesn't work, move on to the mini maze procedure, which is the operative procedure. We also do mini mazes very frequently as part of valve surgery or bypass surgery in patients who have atrial fibrillation because it doesn't add a lot of extra time, not a lot of cutting and sewing. But again, it's not as successful as the actual cut and sew maze.
Simple question with the home monitoring, what's happening at the physician end?
So if you develop a clinic where you use home monitoring, you have to have somebody who's dedicated to look at the monitor every morning. What we get is a report on our patients in the morning, and we get what are called yellow alerts and red alerts. Yellow alerts are typically things where the patient's weight has gone up 5 pounds in 3 days, or the patient's activity has dropped by 30% over the past week. And those things are brought by this dedicated person to the attention of the clinician. And the clinician can decide how to utilize that. Oftentimes, a nurse practitioner will call the patient, have them come in for an examination. Red alerts are actually paged directly to the on-call physician, and those are things like a broken lead or ventricular tachycardias that have not been successfully cardioverted, those types of things. And we get information about that immediately, or at least as soon as the patient gets to the bedroom or close enough to where they can be detected. Now, obviously that's a little bit too late for some things, and that's why we're moving towards cell phone technology for a lot of these alerts.
What are just a ballpark figure for costs of the defibrillator, costs of the biventricular device, with cath lab expenses and so forth, and then the procedure, one of your ablative procedures, and then what's kind of the ongoing yearly cost as well in terms of monitoring?
Right. So there's a lot of question as to cost effectiveness of these devices. I mean, often these devices can be very expensive. The defibrillators last about 5 years and need to be replaced. A pacemaker is around $900. Defibrillator is around $9,000. And a resynchronizing defibrillator is around $18,000. So they're very expensive devices. Over 5 years' time, however, they're very cost-effective compared to other things like dialysis, particularly with the huge amounts of benefit, the improvement in heart failure, the reduction in hospitalization, reduction in caring for patients who have had out-of-hospital cardiac arrest, et cetera. The procedural cost itself, when you add everything, is around $30,000 for a cardiac resynchronizing defibrillator. And the ongoing cost is usually the patient needs to be monitored about once every 6 months, with an office visit, and then the device replaced in 5 years. As far as ablations go, ablation catheters vary from $150 to $3,000 per catheter. An ablation is typically about $30,000 for the entire procedure, including cath lab time, hospital time, et cetera. But that's a curative procedure in the majority of cases and requires no further follow-up after that.
Is a $3,000 catheter one piece?
Yeah, the $3,000 catheters are one-time use. Some of the catheters that we use have 64 electrodes that have to go through a 6 French hole, a 2.5 millimeter hole up into the heart, be bidirectional. These things can't be made by robots. They have to be made by humans in very tightly controlled environments. So they are one-time use catheters, yes. All right, thank you.